Hi, I'm Dr. Mike McInnes. In this lecture we're going to be discussing the high points of two main types of aortic valvular disease, aortic stenosis and aortic regurgitation. We'll discuss how to recognize them on exam, what symptoms and complications you have to watch for, and when you need to refer for surgical repair. And I'll go ahead and mention up front that I won't be discussing endocarditis in this lecture. That's covered separately in the infectious disease lectures. Basically because when you have a patient with endocarditis, he's more likely to be managed by an ID specialist than by a cardiologist. So let's begin with aortic stenosis. Aortic stenosis begins when there's narrowing of the aortic valve, and this restricts the ejection of blood from the left ventricle into the aorta. So there are several causes of aortic stenosis, including a congenital bicuspid aortic valve. Remember, the aortic valve is supposed to have 3 leaflets, but if you're born with only 2 leaflets, that may cause some stenosis of the valve. You can get an aortic stenosis from rheumatic heart disease, where you have fusion of the leaflets. You can get aortic stenosis from senile degeneration, which is one of the more common causes of aortic stenosis, just aging changes and calcification and degeneration of the valve with time. In terms of pathophysiology, this narrowed aortic valve increases the pressure in the left ventricle, and this leads to left ventricular hypertrophy because the left ventricle is trying to pump the blood through this narrowed aortic valve. Because you have left ventricular hypertrophy, you're going to have increased oxygen demand, and you're going to have stiffening of the left ventricle, and this can lead to congestive heart failure. So there are 3 main symptoms you watch for in aortic stenosis. The first is exertional dyspnea, or CHF. Basically, this is the most common symptom of aortic stenosis, and it's the one that carries the worst prognosis. You can also see exertional syncope. You can see exertional chest pain or angina, because basically that hypertrophy left ventricle is going to have increased demand for oxygen, and you have decreased supply of oxygen because of the aortic stenosis. So when you develop any of these symptoms, that's an indication for valve replacement surgery, because life expectancy is usually poor once symptoms of aortic stenosis develop. Now sometimes we'll talk about the mortality associated with these different symptoms. With aortic stenosis-induced CHF, you have a 2-year mortality of about 50%, which means 50% of patients with CHF due to aortic stenosis will be dead in 2 years. With syncope, the 3-year mortality is about 50%, and with angina, the 5-year mortality is about 50%. Now, sudden death has sometimes been called the 4th symptom of aortic stenosis, in that sometimes the first presenting sign is the patient simply drops dead, and so that's not a good thing. Now, it's very important with all these valvular lesions to be able to diagnose the most likely valve lesion based on the physical exam findings, especially the murmur. So let's talk about what the murmur is going to sound like. First of all, with aortic stenosis, this is a systolic murmur. You should be able to reason that out. When is blood normally flowing across the valve? In systole. Normally the aortic valve is wide open, but with aortic stenosis you have turbulence, so you hear a murmur. So the murmur begins after S1, it's distinct from S1, and then it gets louder, and it peaks in mid to late systole, and then it gets quieter again. So it's diamond-shaped, or to use musical terminology, it's a crescendo, decrescendo murmur. And you can usually hear S1 and S2 distinctly. So this murmur can normally be heard in the second interspace on the right, just lateral to the sternum, and it can radiate to the neck or the carotids or over to the apex. Now, this murmur is also often described as having a harsh quality to it. And it's important to note that in aortic stenosis, the loudness of the murmur does not correlate well to the severity of stenosis. So you can't say that just because you have a soft murmur, you don't have very severe aortic stenosis. Now, I want to stop for a moment and say a word about grading of murmurs. You can grade murmurs grades 1 through 6 based on their intensity. And so a grade 1 murmur is a soft murmur. It may be a murmur that you don't hear immediately. You have to listen for a while to hear it. Or it may be a murmur that can only be heard with specific maneuvers. I've even heard it said that a grade 1 murmur is a murmur that cannot be heard by a third-year medical student. A grade 2 murmur is a soft murmur that is readily apparent as soon as you listen to the heart. A grade 3 murmur is louder than this, and there's no objective difference between a grade 2 and a grade 3 murmur. A grade 4 murmur you will have a thrill that is palpable. You put your hand on the chest wall and you can feel the murmur, you can feel the thrill. A grade 5 murmur is heard with the edge of the stethoscope on the chest wall, but you don't have to put the entire face of the stethoscope. You can just hear the murmur when you just have the edge on the chest wall. And a grade 6 murmur you can hear without touching the stethoscope to the chest wall at all. So you really need to know this. It's somewhat subjective, but you don't want to just guess. Most murmurs you hear are going to be a grade 2 or grade 3. Basically, a good rule of thumb is if it's loud, you can call it a grade 3 murmur. If it's soft, you can call it a grade 2 murmur. So again, you can't really listen to aortic stenosis and say that's really loud, it must be severe aortic stenosis, or that's only grade 2, it must not be that bad yet. What else can you see on exam? You may hear an S4 heart sound that occurs when you have a stiffened left ventricle and the left atrium ejects that blood and it hits that stiffened left ventricle. So you can hear an S4. You can also hear an ejection click, which is an opening sound of the aortic valve just after S1. Another classic symptom you need to be aware of is called pulsus parvus et tardus, which means you have a weak, delayed arterial pulse. Basically, you can feel it in the carotids, or you can feel it at the radial pulse. The upstroke of the pulse is going to be weak, and it's going to be slow and delayed. Now, one little pearl for you. If you ever want to impress an attending who says, listen to this patient's heart and tell me what you think the valvular lesion is, don't whip out your stethoscope. Start by feeling the pulse and then inspecting the chest and feeling for the PMI. Attendings absolutely eat that up. A resident is going to say, come on, I said listen to the murmur, quit fooling around with the pulse. But an attending will love to see you approach the patient systematically. So what studies can we do in aortic stenosis? What are the studies going to show? A chest x-ray may show evidence of left ventricular hypertrophy. You may see a boot-shaped heart. An EKG is going to show evidence of LVH. It's echocardiogram that allows you to make the diagnosis definitively, and it can help you determine two key determinants of aortic stenosis severity. The first is the aortic valve area. Now, normally an aortic valve area is about 1.5 to 2 square centimeters. If the aortic valve area is narrowed to less than 1 square centimeter, that's severe AS. And if the valve area is less than 0.5 to 0.6 square centimeters, this is critical aortic stenosis. The other important thing to determine on echo is the aortic valve gradient. This is the difference between the pressure proximal to the valve, or inside the left ventricle, and the pressure distal to the valve, or just inside the aorta. Normally, the valve is wide open, there's not going to be much pressure gradient at all. But if you have a pressure gradient of more than 70 millimeters of mercury, this is critical aortic stenosis. Another test you're going to do in a patient with aortic stenosis is a cardiac catheterization. If you're considering aortic valve replacement, you want to do a cath first before you go to the OR, because if the patient needs bypass surgery for coronary disease, you want to do that at the same time you're replacing the valve while you've got the patient's chest open. The last thing you want to do is replace the valve and then find out 6 months to a year later you've got to reopen the patient's chest to do bypass surgery. So let's talk about treatment for aortic stenosis. Basically, in terms of medical management, there is no treatment. There is no medical management for aortic stenosis. Surgical valve replacement is the only real option. Back in the old days, we used to do something called a balloon valvuloplasty, where you inflate a balloon across the stenosed aortic valve and you try and open up the valve, but that's no longer recommended. Surgery is the answer. Basically, the timing is easy. Wait till symptoms develop. Once there are symptoms, you need to act immediately and go ahead and replace that valve. Now, with valve replacement, you have several options. You have a bioprosthesis, which is either a cadaver valve, or it's a valve made from a pig or cow tissue, or you can use a mechanical valve. The mechanical valves are going to last longer, but they're more prone to thrombosis, so you have to use anticoagulation, lifelong warfarin therapy. And regardless of the type of valve replacement, patients with prosthetic valves need endocarditis prophylaxis when they're undergoing dental procedures or undergoing respiratory tract procedures with biopsy. So let's pause for just another moment and have a word about endocarditis prophylaxis. You may have noticed I didn't really say anything about endocarditis prophylaxis for aortic stenosis. Basically, for years and years, doctors and dentists prescribed antibiotics prior to dental work and colonoscopies and cystoscopies and all sorts of procedures for any patient with valvular heart disease. The idea was that the procedure would cause some bacteremia, and you would seed the valve, and so you would give antibiotics prior to the procedure to reduce the incidence of bacterial endocarditis. Well, this is the age of evidence-based medicine now, and there have never been any good randomized controlled trials that have proven any benefit from antibiotic prophylaxis. So as of 2007, the current recommendations say that endocarditis prophylaxis is no longer recommended for patients with acquired aortic or mitral valve lesions unless there's a history of endocarditis. Now we're going to pause for a quick review.
Whoa, I seriously need to know when you're going to let me borrow that top. Anyway, so during rounds today, I was presenting this patient with syncope from aortic stenosis, and Dr. Wilkerson was all like, describe his murmur. So I was like, it was a harsh, high-pitched grade 2/6 crescendo, decrescendo, systolic ejection murmur radiating to the carotids. And he was all like, did he have strong pulses? You know, trying to trick me. And I was like, cha, as if. The pulses were weak and delayed, you know, classic pulsus parvis etardis, dude. My physical exam skills are like seriously legit. So he sent his butt into surgery. The patient, not Dr. Wilkerson. Okay, so when can I borrow that top? Seriously.
Hi, I'm Dr. Chris Lewis, one of the chief educators here at Doctors in Training. It's time for our quick review. Let's get started. Now, some of these questions that we're going over, we didn't go over with Dr. McGinnis in the lecture, but this is some basic cardiology that you should really know anyway. So first question, which heart valve should blood be flowing through during systole? Well, that's an easy one, aortic and pulmonic valves. Next question, what are the systolic heart murmurs? Good to memorize all these. Aortic stenosis, pulmonic stenosis, mitral regurgitation, tricuspid regurgitation, and ventricular septal defect. Next question. What heart valves should blood be flowing through during diastole? Tricuspid and mitral. Next. What are the diastolic heart murmurs? Remember this as well. This is tricuspid stenosis, mitral stenosis, aortic regurg, and pulmonic regurg. Next, what are the three primary symptoms seen in aortic stenosis? Very important. Remember, you're going to have CHF symptoms, exertional syncope, and angina. Next question. What symptom of aortic stenosis is associated with the worst prognosis? Well, remember CHF symptoms. So you're going to have a 50% mortality at 2 years with CHF symptoms. Syncope has a 50% mortality rate at 3 years, and angina has a 50% mortality at 5 years. So all three of these are very, very important, but remember that the worst one is CHF. All right, so that's going to conclude our quick review. Let's get back to Dr. McGinnis.
All right, next let's talk about another aortic valve lesion, aortic regurgitation, which is also sometimes called aortic insufficiency. Basically, this occurs when the valve doesn't close all the way. It stays open a little bit so that ejected blood is regurgitated back into the left ventricle. So there are a lot of different things that can cause aortic regurgitation, and we have to talk about chronic aortic regurgitation versus acute aortic regurgitation. So chronic aortic regurgitation can be caused by rheumatic heart disease. It can be caused by congenital deformities of the aortic valve. It can be caused by endocarditis. And it can be caused by a lot of diseases that cause dilation of the aortic root. Things like Marfan syndrome, tertiary syphilis, anything that makes the aortic root dilated is going to pull those aortic valve leaflets apart, so you'll have some aortic regurgitation. Now when we talk about acute aortic regurgitation, we're talking about acute endocarditis that can destroy the valve leaflets. You can talk about aortic dissection, which causes an acute aortic root dilation, and then trauma can also cause some aortic root, or some aortic regurgitation. So the pathophysiology of aortic regurgitation, basically you have volume overload of the left ventricle because volume that's supposed to be ejected back out into the aorta is regurgitating back into the left ventricle. So you get volume overload, and over time that's going to cause some left ventricular hypertrophy and left ventricular dilation. You get a large stroke volume with aortic regurgitation, but that diastolic pressure is going to drop off quickly as the blood is leaking back into the left ventricle. So you have a wide pulse pressure. You may have a very high systolic pressure and a relatively low diastolic pressure. So the symptoms of aortic regurgitation are going to depend on if we're talking about acute or chronic disease. With acute aortic regurgitation, we're talking about rapid onset of congestive heart failure and cardiogenic shock. So you get acute onset of dyspnea, tachycardia, hypotension. Basically, acute AR is an emergency. With chronic AR, you're going to have insidious onset of CHF. So you'll have exercise intolerance, you may have orthopnea, you may have paroxysmal nocturnal dyspnea. Patients may have palpitations, they may have some chest pain. So let's talk about the exam and the murmur. First of all, is this a systolic or a diastolic murmur? Well, during diastole, the aortic valve should be closed. But if blood is regurgitating across the valve during diastole, you'll get a diastolic murmur. So this is a high-pitched, blowing, diastolic decrescendo murmur that's heard in the aortic position in the right second interspace. This is best heard with the patient sitting forward slightly and holding their breath in exhalation. You tell the patient just breathe normally and then stop when they exhale. You tell them stop breathing and you can listen. And that's the best way to hear aortic regurgitation. This murmur may radiate to the apex. You can also have what's called an Austin-Flint murmur. Now, this was not named after Dr. Flint and Dr. Austin. It was named after Dr. Flint, whose first name was Austin. So this is an Austin-Flint murmur. This is a rumbling mid-diastolic murmur that's heard at the apex with aortic regurgitation. Basically what happens is the regurgitant jet of blood pushes against the anterior mitral valve leaflet and pushes it partially closed. So you have some functional mitral stenosis. This is really only seen with severe aortic regurgitation. So in addition to the normal blowing decrescendo murmur of aortic regurgitation, you may have this rumbling mid-diastolic murmur at the apex, which is the Austin-Flint murmur. Other exam findings, and there are a lot of them with aortic regurgitation. We already mentioned the widened pulse pressure. You may have a blood pressure of 150/60, so that pulse pressure is very wide. You have a hyperdynamic bounding peripheral pulse. So when you feel the pulse in the carotid or the radial pulse, you're going to feel it really pounding. This is sometimes called a water hammer pulse. You can have what's called de Musset's sign, which is where the patient's head will kind of bob in time with the systolic beat. De Musset was a French poet who had aortic regurgitation, and his brother noticed this bobbing of his head, and that's where the name comes from. You can also have what's called Traub's sign, which is a pistol shot sound heard on auscultation of the femoral arteries. You can have what's called de Rosier's sign, which is a diastolic murmur heard over the femoral artery during distal compression. So you listen to the femoral artery and you compress distally to where you're listening, and you can hear this diastolic murmur. A systolic murmur is normal. Everyone will have that when you begin to compress the femoral artery, but the diastolic murmur is noted in aortic regurgitation. You can also have left ventricular hypertrophy and left ventricular enlargement, so the PMI may be laterally displaced. Now, let's talk about treatment for aortic regurgitation. We already mentioned that aortic regurgitation acutely is an emergency. You need to emergently replace that valve. Sometimes you use an intra-aortic balloon pump in order to bridge the patient to surgery because you're treating their cardiogenic shock, but ultimately you need to go to the OR and replace that valve. Now with chronic aortic regurgitation, you can try medical management at first. Unlike aortic stenosis, where there is no medical management with aortic regurgitation chronically, you can do medical management. Basically, you're going to use vasodilators such as nifedipine or hydralazine or even an ACE inhibitor to reduce afterload and reduce the volume of blood that regurgitates into the left ventricle. Patients who have more than mild symptoms may need to undergo valve replacement surgery, or if they have progressive left ventricular dilation and ejection fraction less than 50%, they may be candidates for valve replacement surgery as well. Well, that's all we have to say about aortic stenosis and aortic regurgitation. Now it's time for your end of session quiz. So I want you to pause the video, complete the end of session quiz questions in your study guide, and then restart the video to go over those answers.
All right, we're back, and now it's time for our end of session quiz. Our first few questions here were also not covered in the lecture, so we're going to go over them with a little more detail as well. So let's get started. What conditions place patients at the highest risk for development of infective endocarditis and therefore require antibiotic prophylaxis during high-risk procedures? So we're going off of the 2007 guidelines that were published by the American Heart Association. So let's go over some of these conditions. So prosthetic heart valves, prosthetic material used for cardiac valve repair, a prior history of infective carditis, so they've had it before, unrepaired cyanotic congenital heart disease, completely repaired congenital heart defect with prosthetic material or device during the first 6 months after the procedure, repaired congenital heart disease with residual defects at the site or adjacent to the site of the prosthetic device, and cardiac valve disease in a transplanted heart. So these are all the conditions that are important to remember, and relatively fewer people than in the past. We were using medications to prophylactically protect them against infective endocarditis, but as of 2007, we have a shorter list of people that we need to prophylax against. Next question. What procedures place patients at the highest risk for bacteremia and therefore would be an indication for endocarditis prophylaxis in the appropriate patient? So now we're looking at the type of procedures, not the condition. So procedures. First one, dental procedures associated with gingival manipulation or perforation of the oral mucosa. Respiratory tract procedures with incision or biopsy of the respiratory tract mucosa. So think of a tonsillectomy. Think of bronchoscopy with biopsy. Surgery on infected skin or musculoskeletal tissue if infected with staph or beta hemolytic strep. GI or GU procedures are no longer considered high risk for bacteremia. They were in the past, so if you have an older version of your guidelines, make sure you realize now GI, GU procedures no longer considered, so no antibiotic prophylaxis is recommended. Vaginal delivery and cesarean delivery are not considered high risk either. So remember GI, GU, and that's including vaginal deliveries. So just to be clear, the guidelines say that patients with one of the high risk conditions in question 1, remember we just went over that long list of the type of conditions, when they're undergoing one of the high risk procedures in this question, so it should be fairly uncommon to give prophylactic antibiotics for the prevention of endocarditis. We were given it a lot more often in the past, not so much now. Next question. In a patient who requires endocarditis prophylaxis, what antibiotic regimen is appropriate? So we've fulfilled our 2 requirements. We're going to give someone antibiotics. Well, what are we going to give them? Well, generally we prescribe amoxicillin, and we give 2 grams orally 30 to 60 minutes before the procedure. If you have a penicillin allergic patient, then you could use cephalexin, and you can use 2 grams, or azithromycin, 500 milligrams, or clindamycin, 600 milligrams. In patients who can't take oral medications, you can use ampicillin, 2 grams IV or IM. Penallergic patients may be given IV or AM ceftriaxone, cefazolin, or clindamycin. Next, what lesion is associated with the following exam findings? First, crescendo decrescendo systolic murmur, heard best in the 2nd or 3rd right inner space close to the sternum, and that's going to be aortic stenosis. High-pitched diastolic murmur associated with a widened pulse pressure, aortic regurg. Water hammer pulse or bounding hyperdynamic pulses, this is going to be your aortic regurg. Pulsus parvis et tardis is a weak pulse with a delayed upstroke, that's aortic stenosis. Demusset sign, this is when the patient's head is bobbing with the pulse, and that's going to be aortic regurg. Traub sign is a pistol shot sound heard over the femoral artery, and this is going to be aortic regurg. Next question. What conditions can cause acute aortic regurgitation? So this is going to be acute endocarditis, so the valve destruction and perforation of the leaflets, aortic dissection, and then trauma, so blunt trauma, sort of this deceleration injury, think of a motor vehicle accident. What is the preferred medical management of chronic aortic regurgitation? So we like to use the vasodilators, so nifedipine, hydralazine, sometimes ACE inhibitors. These will reduce afterload and then reduce the regurgent volume. Next question. What is the preferred medical management of aortic stenosis? Well, the answer to that is nothing. Aortic stenosis is only treated when it becomes symptomatic and then only with valve replacement surgery. Next, What two echocardiographic findings indicate critical aortic stenosis? So if you have an aortic valve area of less than 0.6 centimeters squared, or aortic valve gradient greater than 70 millimeters of mercury. Next question. Which type of prosthetic valve would generally be recommended to a 78-year-old patient with aortic stenosis? So we have two choices here. We have the bioprosthetic valve or a mechanical valve. Now the bioprosthetic valves last on average about 10 years. They seem to last a little bit longer in older patients as well, and statistically speaking, a 78-year-old patient is less likely to live more than about 10 years. So that potentially could be a good reason to use the bioprosthetic valve. Also, the mechanical valves will require chronic anticoagulation, and this is potentially more dangerous in your older patients because they're at high risk of falls. You anticoagulate them, they bonk their head, and then lo and behold, they have an intracranial hemorrhage, and you've done more harm than good in this situation. So, bioprosthetic valve would probably be a good idea in this patient. Next question. With what valvular lesion may an Austin Flint murmur be heard? So this is severe aortic regurg. So remember, an Austin Flint murmur is the rumbling mid-diastolic murmur at the apex caused by the regurgitant jet causing partial closure of the anterior mitral leaflet. All right, so that's going to conclude our end of session quiz and the end of our lecture. Hope you learned a little something, and good luck studying.